Well, I'm really excited to be here. It didn't even feel like I felt like I sort of knew everyone, so it's been a super fun visit. So I'm excited to share with you kind of my journey in quality improvement and hopefully give you guys some ideas about what I think the next decade will look like and how we need to position ourselves. So I've received funding over the years for this. And then I was going to just share some of my experience with local quality improvement, national quality improvement, kind of the tensions as you try to scale stuff, what I think are enablers and barriers. And then, like I said, some suggested paths forward. So I think the reason why we go down this quality improvement path is we have really unexplained persistent variations in care. And I think, this is what kind of resonates with all of us as surgeons is we're really a clinical field. We do a lot of direct patient care, and I think we all feel like we can do better for our patients. This is sort of ingrained in the surgical culture, is why I think, quality improvement's really taken off in our field. And then this is a slide from last year's Quality and Safety Conference of just how we start to think about how all these pieces fit together. And if you think about patient care is what we do every day. And then evaluation is sort of part of our culture too, whether you think about it amongst M&M or the registries or hospital level data. And then how do we get to quality improvement, which is basically just reiterating this cycle and just having this continual improvement. So I got into this in 2010, and I just put the dates on these slides just to put it all in perspective, because I think it's kind of how I started, and where if you're getting into this now, it's different, not better or worse, it's just different. And I think like everything else, we need to keep reinventing ourselves and keep thinking about our approach. So I got into this in 2010 when I worked at Hopkins, and we had participated at the time, it was a pilot program of ACS NSQIP, where we collected all of the outcomes for colorectal surgery. And it was basically the preamble of the targeted procedure module in the registry. So instead of, in the old days, it was all just a random sample of patients, it was hard to make sense of, but all of a sudden we had this cohort of, say 200 or 300 colorectal operations at Hopkins, and we got our report back, and we were terrible. This was the caterpillar plot that NSQIP used to give us, and Hopkins was on the far right, which was bad. And I just put in the bottom there, the rate at the time was 30%, so it was really high. So there was a lot of opportunity. And then on the right was actually a patient that we took care of at Hopkins, a cirrhotic that had obstructing sigmoid colon cancer and ended up with this terrible wound infection that actually was fatal. So, I mean, we were seeing a large number of infections and serious ones. So I got sort of down the path of trying to think about how to improve it. And then I'm just going to sort of go through now how I worked through this at Hopkins and got into enhanced recovery. So I had the good fortune of, at the time, there was an intensivist at Hopkins, Peter Pronovost, who similarly, for a problem that was sort of just as kind of out of hand at the time, got involved in improving CLABSIs in the ICUs. And in the early 2000s, so just before this, he'd done some work first at Hopkins, and then in the state of Michigan, it was called the Michigan Keystone ICU Project. And it was a bundle to prevent central line infections. And the unique thing about when Peter did this bundle is he thought about it not just as a checklist, and there's lots of stuff written about the checklists, but there, you needed to wear a gown, you needed to drape the patient, all these things that actually we never did at San Francisco General when I was a resident. I'm sure Andy didn't do them either. I'm sure he was wearing a fleece when he was putting in central lines too, in the 4E ICU, but I won't go there. So Peter came up with this checklist. But then the other thing, as Peter was looking at the CLABSI bundles, is thought about it not just as a checklist, but how do you motivate people that this is a preventable harm, that we really need to follow this, we need to believe in this. And that was this model of the technical work and the adaptive work. And there was a sweet spot between the two. And to get at that kind of adaptive work and get people, get their heart and soul behind the work, he had this model. It was called the Comprehensive Unit-Based Safety Program. And it was a 5-step idea. And it's actually, now it's sort of, you see all these principles woven into whatever implementation models you see out there, but it was sort of avant-garde at the time. So he thought about, just general awareness that this was a problem and to think about it as a system, whether it was that you didn't have access to gowns to not, to put in the line sterilely, but really introduce this idea of systems thinking and awareness of the problem at the unit level. So really at the front line, Peter was really focused at where the rubber meets the road. And then to empower the staff, the people who touch the patients, to help identify and resolve patient safety issues, support folks and integrate like standard work and getting, being able to standardize care. And then the other big deal was he had this idea of bringing the C-suite as an executive kind of sponsor to the projects, just to bring that bridge between the front line and the senior leadership, but to demonstrate how important the work was, and then also to address barriers. And then it was basically a cycle of learning. He called it learning from defects. And the interesting thing, I think everyone knows the story about the CLABSI story, that yes, it was a huge success. And probably we haven't matched that level of success that they saw in that Michigan effort since then, that degree, a magnitude of improvement. But the interesting thing when you looked at the data from the Keystone work was that this graph, every bar is an ICU in the state of Michigan that had participated in the Keystone project. And they also measured safety culture surveys. And this was sort of one of the first times that concept was out there. And what they found was the units that were most likely to eliminate CLABSIs were those where caregivers felt comfortable speaking up if they saw a problem with patient care. So again, getting at this idea that people started to believe that these things were valuable and they advocated for the patient. So again, it wasn't just another checklist you were doing, you truly believed it was helpful. And that's this kind of idea of blending the technical and adaptive. And I think, hopefully you see throughout my talk just how important that is. And I just think it's harder and harder to get to the heart and soul of people, even though we all want to do the right thing, but that's the crux of this. So getting back to the Hopkins SSI problem, I'd met Peter, I'd seen this model, and I had the good fortune of sort of working together to think about how we could take these principles to our surgical site infection issues. And this is something that was in the done in the ICUs and the CLABSI work, and it was a really simple concept. And actually, I think we probably don't use it enough, but it's this idea, that last step where he wants you to keep identifying defects. And it was a paper survey. We called it the 2-question survey at the time. I think it got renamed the staff safety assessment. But you can frame the questions any way. You can use these questions however you want. But how will the next patient be harmed, or in this case, have a surgical site infection? And what can we do to prevent the next patient from being harmed or an SSI? And basically, it was a paper survey. You handed it out. Everyone wrote down their answers. And it was just an idea that many people aren't comfortable speaking up in meetings, whether it's the tech or the clerks, but everyone has an idea. And again, this is 2011, and this is when we did this, but just as an example of kind of where we were with SSI back then, which is, hopefully you'll realize we were at a very different place then. But when we did that staff safety assessment, one of the things that came out was, and it was kind of shocking because actually Mary had done all the work on the skip measures at just about this time. And but we uncovered that actually if you had a penicillin allergy, at Hopkins, we used Clinda and Gent as our for penallergic patients for colorectal surgery. And when we did the staff safety assessment, all the CRNAs and folks were like, oh, well, we never give that Gent. So we weren't even giving the antibiotics that we thought we were giving. And they said, oh, people were nervous about the Gent. They didn't know how to dose it. No one knew, it's just sort of a foreign, scary antibiotic. And at the time, and this is again the problem with all of these publicly reported metrics, is the data isn't that, like, it's sort of good, but it's a little bit gamed. And so the actual data you reported to CMS could be a random sample. And we went back and looked at our random sample. We didn't have a lot of penallergic patients. So although we performed well on the metric, this little piece was missed. And then when we looked, these patients, perioperative antibiotics, at least that incisional dose does help. And so there was a higher rate of infection. So anyway, this is the kind of information that you can glean from the frontline. And then sometimes everyone is just so busy. I don't know if it's a culture of intimidation or just people don't have time or avenues to speak up. So I think, just thinking about different ways that we gather that info is key. We come into meetings too often just with preconceived notions. So with that, a cusp and an SSI bundle, and kind of, I won't go into the details because I think everyone is familiar now with how to prevent, what the colon SSI bundle is. But we got that into play and really worked on the culture and, iterating stuff and continually identifying defects, and got that SSI rate of 30%, kind of down to about 15%. And then started to look at it in about 2013. The enhanced recovery was becoming sort of clear that there was another opportunity around these really long lengths of stay in colorectal surgery. So again, it was another moment in time where it was clear that we were like 2 or 3 days longer than you needed to be. In the SSI, we were probably more than double what you needed, what we should have been. So really huge gaps. So again, then we added the enhanced recovery and we placed it on this model and saw a pretty rapid improvement. The whole team kind of gelled. We got our SSI rate down, we got our length of stay down, decreased cost, improved our patient experience. We scaled it in our little health system. And then I kind of wanted to look and take a step back and say, hey, Peter had started that CLABSI work in the ICUs at Hopkins. He had taken it to the state of Michigan, and then it eventually went across the country. So I wanted to see if we could scale this kind of model similarly. So everything with the government takes a really long time. So we had this idea kind of in 2013 or so. It took till about 2016 to get it funded by AHRQ. And it was funded then as a 5-year collaborative that it wasn't tied to a state. So it was for the whole country, virtual collaborative. That was a collaboration between the Hopkins Safety Institute, the American College of Surgeons, and AHRQ. And I think that's just an important point because it was very much a collaboration between those 3 stakeholders. And we all had different agendas, so sort of moving it forward was challenging. But the collaborative was we enrolled hospitals. They had access to an evidence-based toolkit. We did all these systematic reviews, were clear. There were implementation guides, sample order sets, webinars. We met in person at the NSQIP meeting. We went places. So just a lot of networking and support. And it was all sitting on whether you were a NSQIP hospital or non-NSQIP hospital. One thing we'd heard from prior work was that data collection was an issue. So it was all sitting on the ACS registries with high quality data. So we had about 300 plus hospitals participate over the course of the collaborative. Most hospitals participate in colorectal surgery. This was sort of at a time where people, I think, if they didn't have an ERS program, they felt behind. But we also did gyne, ortho, emergency general surgery. So you kind of had a menu you got to pick from. You had to start at the same. We had 4 people joined in a cohort with this idea that the cohorts collaborate. So you had to pick a start date over that. There were set start dates. And I'm going to share a little bit of what we found. So number one, this is really, really hard. And so there was this vision that it was like 3 months that you could kind of, you were given this package, you could figure out in your hospital environment and then implement your ERS pathway and then collect data. And so what we found was that basically hospitals were just implementing over the whole course of the cohort. It was really hard. And there's just so many factors at play locally that you couldn't overcome, that there was no way you could have sort of a strict study here, which I think was AHRQ's vision, that we would be able to line up all the dates and be able to demonstrate impact. Just things happen at different places at different hospitals for a host of reasons. And this data is from a cohort pre-COVID. So we have some COVID cohorts too. So again, 3 months was nowhere near enough to get things going. And then what we found, and I think this is just important as you reflect on if you're asked to do something in quality improvement, is again, remember this was like 2017, 18, 19. And the pathways had the standard process measures you would think about, oral antibiotics, mechanical bowel prep, multimodal analgesia, early mobilization, early refeeding, and both solids and liquids, amongst other things. Those are the data points. And what we found was that the process measures improved at the participating hospitals, but they didn't improve by that much. It was really hard. So again, we're starting into, people had sort of, some of this stuff had already infiltrated in, so the low-hanging fruit had been done, and then the next level of improvement was really hard. And the process measures that improved the most were the multimodal pain control and the bowel prep. And I think that's probably for a couple reasons. One, the evidence was strong, they're very discrete. And then I think we all know that when you're thinking about what your quality improvement project is, it really, you need to be able, and this data was going into a registry, but you need to be able to measure it. And the easiest thing to measure are the things on the MAR, because we have to record that. And so other things like early mobilization and even diet is very difficult to measure. So we didn't really move the needle on those. We moved the needle on the things that could measure. And then this is actually, Tajan is a resident at Ohio State, and sort of just took all of this data from all the colorectal process measures, and then basically tried to think about the missed opportunities here. And basically the bottom line is about, in this cohort that he picked of colorectal hospitals, we saw substantial improvement in about 15% of hospitals. And actually the vast majority just had minimal improvement. They just kind of stayed along. And a small cohort had worsening compliance. So there were just tons of kind of missed opportunities in improvement. And again, I'll show some more explanation, but I think one of the things is, you know, when we had started this stuff at Hopkins in 2010, we were starting at the very bottom. And when we came to ISCR, people had already started tinkered in this stuff, and getting that last little push to like excellence is far harder than when when you're starting from ground zero. And then we took a deeper dive to understand, you know, recognizing that it was really hard. We didn't get the global improvement that we had hoped. You know, could we understand who was able to move the needle? And what we found is that you were actually, the cohort lasted for 18 months, but you could stay in the program longer just to get support and use the data platform. So those folks that did actually move the needle, they participated for more than 2.5 years. So there was like some real grit in this. They tended to actually be smaller, or not tiny surgical services, but mid-sized hospitals. And then I think this is key. They were hospitals that had really no prior QI experience or enhanced recovery experience. So they were really coming to it kind of without the skeletons in the closet. Because those skeletons are, you know, those issues have to be dealt with locally, and it's really not something a collaborative can overcome. What we also found is, again, every hospital invested a ton of resources in collecting data on the ACS platform. And what we found was just collecting data alone did not make a difference. Collecting data and sharing it up, I think we've all seen those, whatever, True North cards, scorecards, where data is put in front of leadership, and hospitals that just did that didn't make the difference. The hospitals that moved the needle were ones that brought it to the front line and brought it up. So again, kind of taking us back to that old CLABSI work, but how important it is both to tap the front line for their wisdom, but also share the data with them. And I think it's just something, and I just reflect on UCSF now and all the changes with COVID, and we're just not together, and we're doing so many quality improvement things, so many things, and I just think we're missing some of these elements today. So I think, you know, it was a great experience. We're grateful to all the hospitals that participated. I think we learned a ton. What we learned was the really strong forces in success of this enhanced recovery SSI type of stuff is so local. It's timing, like electing to join something at the time that's right for you, not kind of feeling external pressure that, oh my gosh, this is a college program, we're never going to get this opportunity. If it's not right for the hospital, it's not right to do. You need to stick with it a long, long time. You need to be in it for the long haul with the ups and downs. And then the local context, culture, willingness to change all really, really matter. The people, the skill set, you have the resources, all really drove what we saw. And honestly, I think this idea that the collaborative and peer learning, it's helpful, but I think just where we are today, the local forces are far stronger than anything these collaboratives and peer learning can overcome. And I also think we had this idea that the college data would be the thing that, oh my gosh, the surgeons would be like, oh my, this is awesome data. I believe this, I'm gonna change. And I think, data is data, and doesn't matter that much if it's on the ACS platform or not. I think whatever data you have, as long as you collectively believe it, whether it's out of your Epic instance or Vizient, I think these kind of myths around, we just all need to believe in it and use it, but it doesn't have to be one type of data. And so again, I think just getting back to there is this sweet spot that this adaptive piece really, really makes a difference. And I think we don't exactly know how to move the needle on that, but it is such an important part of all of this. So then in parallel to doing this, I was just going to share some of my recent experiences from UCSF and just put other food for thought out there about why I think things work and don't. Things that are thrown out there is, do we need financial incentives in our payment model to do this? Again, I feel strongly about this, but I think the local hospital and team structure is key. Another thing that comes up is, are we not using the electronic health record to our full benefit? Are we making things too complicated? Are we doing things where the evidence isn't strong enough? This is going to one example on the electronic health record, where I think I was talking to Shilpa yesterday. It's an essential partner, but you need to be very careful in how you use it. So this is Elizabeth Lancaster. She's a surgery resident. She's our vascular fellow, and her husband was a urology resident here. So it looks like I see people nodding on Elizabeth. So Elizabeth's awesome. So she did some opioid work with us, what everyone was doing opioid. We know there was a crisis, we were prescribing too many pills, and we decreased. That was very easy because I think we all just had extreme fear and guilt of prescribing. But the interesting thing when we looked at our data was that we ratcheted down, and I've talked to Mike Engelsley. I mean, I think you see this around the country. We all were able to ratchet down our opioids, but we didn't see that same uptick in non-opioid analgesia. So we were just cutting back, and we weren't necessarily following all the evidence. So, why don't we prescribe NSAIDs? Are we still fearful of the complications? What is the issue? So Elizabeth and Tassi did a systematic review, just looking at the, just making sure, looking at the evidence again, to look to see that, NSAIDs were safe in our patients, which of course they were. And then then Tassi is a trauma acute care surgeon at UCSF, and she, right after Elizabeth, she joined the faculty, and she did the AHRQ Learning Health System KL2 program. And so she did a pragmatic trial embedded in our EHR where we randomized our providers at the provider level. So you were either, for a year, you were randomized to order set A or order set B. In order set A, if you were a provider in that group, you always you had that analgesia panel presented to you, and you had a hard stop that you had to say yay or nay on NSAIDs. If you're in group B, you had that same order panel, but it was pre-checked for the NSAID. And then the outcome that she was trying to improve was both the patient's nurse pain scores assessed by the nurse, and discharge opioid prescriptions. So what did we find? Pre-checking did significantly increase provider ibuprofen prescribing. But interestingly, we saw no impact on the pain scores or discharge opioid prescribing. There was a slight, we looked at ICD-10 discharge diagnoses for GI bleed. There was a slight increase, but it probably wasn't significant. And so, why? Was it too pragmatic, too heterogeneous a population. We did it across surgery, and then we actually did it across medicine too. But it doesn't pan out in either group. Was it a poor outcome measure? So now we're stuck with kind of this data, this order set, and it just finished this winter. And so we have a lot of meetings about what do we do now? Do we remove our trial achieved what we wanted to? We increased ibuprofen prescribing, but it didn't lead to patient outcomes. So do we remove the pre-check because it didn't improve our outcomes, or do we leave it because it should have worked? And I think, we just don't know what. I think we'll probably remove it because if we trust the results, and that was in our intention, was to change the outcomes. And polypharmacy isn't good, but this is just an example that I think the EHR is super powerful. We need to use it more, but we also need to be very thoughtful about what we do in it because it's super messy and it's difficult to figure out what to do. So I think the EHR is a powerful tool, but you need to use it wisely. The next piece that's thrown out there is incentives. And when I went to UCSF, I somehow got met up with the VP of Pop Health. Her name is Gina Intinarelli, and Gina's always trying to think of something new to do. And so they had a lot of success. There was a man named Kevin Bozick at UCSF, and they'd had a lot of success with the ortho joints bundled payments. And so Gina was looking for more things to test this model in. So she thought, well, why don't we do it in the general surgery model? And I was like, I don't know if that's going to work out so well for us. We're not like ortho. Every case is so different. And I don't know. But anyway, she was really hot to trot on this. So this is this idea that you're paid at the episode level. So you're paid as soon as a patient with that meets that criteria is admitted to your hospital and undergoes an operation. For the full 90 days afterwards, you're paid a lump sum of money that you negotiate with CMS. And so we were paid about $60K when we started for each episode of patients that came in with they met the DRG for major bowel procedure. And so it was like colon, small bowel, emergency elective cases. And then we were accountable for basically managing that patient for 90 days. And if our costs, whether it was like the SNF or the home health or TPN or readmission, if we kept that under $60,000, we shared the savings with Medicare. And so we did a ton of stuff. We tried to, look at frailty, understand our risk, optimize. We pulled in kind of all little pieces we had around. We worked hard on our SSI bundle, our ERAS, prevent all our stuff in the hospital. And then when the patients left, we did a lot of, outreach and leveraged our kind of ACO framework. So what did we find? I would say in year 1 and 2 of this, and this was pre-COVID, we significantly reduced our really moved the needle on the quality outcomes, the 30-day. We reduced the readmissions, we reduced the ER utilization, and we had about $1 million in shared savings for CMS and UCSF. It was a 60-40 split. So we got a big chunk back, and then everyone was very excited. The problem with the model, though, is every year you renegotiate your target price. So we performed so well that they ratcheted down on the target price. And then in year 3, basically, there was COVID. Our target price was really stringent, and there was just many things out of our control. And we just all of a sudden started to hemorrhage money from this program. And we had to get a rapid exit strategy. So we ended up losing about $500,000, and we bore the burden of a lot of that. So I think, what did we find from this? That I think, initially the financial incentives, knowing it's a CMS program, was really helpful for getting resources to general surgery and alignment and resourcing. We found, very similar to what we found in ISR, is that improvement is not linear. When you start, really, there's that initial big gain, but then CMS is expecting us to keep on that trajectory with the way they do the pricing, and that is just not the way this works. that, like I said, like the Amazon model, that the last mile is the hardest. When they do their delivery models, that last mile is the hardest. That is true with this too. And then I think, for CMS, that finance is just one, that is the domain they are focusing on for this largely, but it's just one domain. So I think this dilemma was a little easier. We knew we couldn't just double down and try to beat the system. It was getting to be a very expensive experiment. So we picked B and just cut our losses and bailed on this. But I think we learned a lot in the process. I think our patients were better. And I do think somehow someone out there needs to think about how to redesign the payment system in a way that is a little bit, that gives us some little fire in our step, but doesn't penalize us to the extent that this did. And I think this is my last kind of point about what I've learned over the years, is that I think how we do this matters. And I'm sure I'm speaking to the choir here, but then I got, actually, because of the bundle payment, there was a tiny, tiny quality metric in it, and that you needed to increase advanced care planning because it's a CMS program in older adults. And that's kind of their go-to quality metric. And anyway, we were not able to do it. But then I got interested in that question afterwards, and with a couple other residents, Joe, Lynn, and Alexis Colley, two colorectal bound residents, we decided to take, even though we were bailing on the CMS program, we decided to still, Joe did a palliative care fellowship and Alexis is doing one. And we decided to go all in, try to think about how to get advanced care planning to surgery, because it's clear that that kind of metric is probably going to be in other CMS programs. So it felt like a valuable thing to tackle. So we did sort of the traditional, like we looked at advanced care planning. We doubled down on education. Can we get the surgeons, the residents, the advanced practice providers, the patient? Can we educate everyone? Can we get this stuff in the chart? And I think what we found was that that really, like, and it's, we know that out there that education doesn't work, and it didn't work. We got it from 9% to 16%. And I wanted to put that in there because actually Alexis and Joe just published this in Surgery, and I think it's important because it was published under the context that this is sort of a failed QI project. And there's such a publication bias as well in all of the QI that even if your work doesn't work, if you think about it with kind of a framework and an approach, I just want to encourage you to share that, because we were really applauded for sharing that. And so I think that's an important point. But again, you can't publish a failed project unless you sort of had methodology and a framework. So our failed approach kind of led to a much more systematic approach, and partnering with geriatrics and thinking about how to leverage the EHR and message patients, engage patients, and try a virtual healthcare navigator. And that will roll out. That's a NIA-sponsored pragmatic trial, 3-arm pragmatic trial, to see if we can kind of come up with a better system that's not just leaning on our surgical teams, that like really have our surgical teams doing surgical care and think about how to help patients do this outside of that direct surgical team with a navigator or electronic tools, and then just have the stuff ready in the event something happens, but not get the surgical team involved. So we'll see what happens. We don't know what we'll find. So I just wanted to leave with this, that I think you're thinking about starting a QI project, we need to take a step back to really understand what are the priorities today, not just because SSI was a priority in 2010, does that mean what we should be focusing on now? We really need to be forward thinking about what our priorities are. And I think you need to be able to say no. It's okay. Like we get called by the hospital by different people, and you get some email from the ACS, or from your society that we're starting this collaborative, we're starting this project. And if it's not the right time, you just need to say no. We feel so pressured to say yes on everything. And when we decide to say yes, you need to get Dr. Hahn, you need to get Neeraj, you need to get all these people involved, to make sure everyone's behind you in saying yes, because your time is valuable. And so everyone needs to be all in. And I think you can't forget the value of the frontline, whether it's giving them the data, treating everyone, listening, And I think we all think we listen, but that's why that old two-question survey was so powerful, because we're just not that good at listening in a conversation to all these diverse voices. So even giving people the chance to write something down, I think was really powerful back then. And then I think we've really accelerated the science of health services and surgery. And we need to, like, quality improvement is sort of on the very implementation end of health services research. And we need to bring that same excellence that we're bringing to health services to improvement work. And, take the time to reflect on what worked and, importantly, what didn't work. And I feel pretty strongly that, our next generation needs to figure out how to share some of these projects that didn't work. And so I've done this a long time. This is my older son, and he's grown up a lot over this time. He's 13 now. So this is a lot of years of sort of things that worked and didn't work. But I just, look to the future, don't look to the past. And I think all this noise, when people say, like, there's a little wave in the UTI or a little wave in the SSI, none of these waves are very big anymore. And I don't think we need to, totally tear down the house about it. Like, think about really exciting things that are going to really be impactful to the patient, in your field, really, invest in things for the future. And I think the academic community is super powerful. We're so lucky to be on that. And we need to do our quality improvement in a way that is academic. We need to do it differently. We need to leverage our learners' scholarship, use it for career advancement. And I think, really the next decade is going to be where we really see the movement. And, most importantly, I think we're all clinicians and we need to do it for our patients. So happy to answer any questions, and it's really fun to be here.